that they haven't gotten that sick, right? So one of our tactics is to try to keep individuals as far away from the building as possible, the facility as possible, using telemedicine, phone lines. A solution like that would be good because one of the largest exposures are healthcare workers, and we've already got kids out of school. If they get sick, we've already started to quarantine some, so we will slowly lose our healthcare workforce. And I think the more we can centralize some of this, but also have our own solutions, the better we would probably be from many different perspectives.
So I will leave it to each one of the 4 hospitals to find their own solution, their individual solutions. What are we going to do together? That's what I want to know.
The other thing is the message has to be consistent. The messages that are being delivered from different institutions are kind of where to test, how to test, what are the criteria to test. I think that message should be consistent across across all the
message
hospitals.
is you're not going to be tested unless.
Yes, right.
I think that we got to change the dialogue about I need to be tested right now because we just explained why that's going to be mighty difficult. So the only way you're getting tested is.
Amanda, what are the criteria? What are y'all's criteria for who needs to be tested?
It's a good question. I mean,
y'all the experts in this, not me.
I would say now that there's community spread confirmed, the travel question matters very little. Obviously, you can identify very high-risk people. If they came from Italy, they're very high risk. But if they have never been outside of Placer County, there's still risk. That there's no one with no identifiable risk anymore. The risk factor is living in Placer County. I think that part of the criteria has had to go down. We have pretty strictly. You need a flu and RSV before we do anything else. If you have flu, statistically, that's probably the cause of your symptoms. We know it's not protective for COVID. You could also have COVID, but we have an explanation. We don't need to keep digging. And so that's been sort of the bare minimum. We've been using travel as a reason to push with testing. And now obviously we're getting calls from people who say, I sat in a car with someone who has tested positive, and I think that's a huge risk factor now.
Then let me just play that down. So you sat in the car with someone, you're asymptomatic, and you say now you're going to self-quarantine for 2 weeks. At the end of 2 weeks, what do you tell them?
The 2 weeks is self-quarantine. That's the maximum time. Most people will start exhibiting symptoms in 3 to 5 days, and that's when they're infectious. If it comes at the end of 2 weeks, they need to be let out.
How do we monitor those people? How do you monitor someone that we tell to go to be quarantined for 2 weeks?
This is what the health department is doing. We have a layer. We find out a case, whether it occurs at UMS or whichever thing, or whether it occurs in the community. We find out the place, interview the persons who are the patients or their family, figure out where all they have been and figure out the closest contacts. We make a list of that. We have, UMS is a close partner, so they are doing that for their people who have been exposed, and they have access to our database that they are doing monitoring. So we monitor them every day, its closest contacts. And if they become symptomatic, we test them because the yield of the test is higher at that time. So that is how we are monitoring and investigating. Again, after the primary, the chance of that person being in contact with someone else, that unless they are symptomatic and is very less. Primary, secondary, tertiary contact, we just are worried about the first contact now, the closest contact. Later on, if they become symptomatic, we'll expand the circle of testing. And ADH has a database specifically meant for this. We have given access to UMS. If Baptist wants to load all their contacts in that, we can have that, so that we have a centralized database where the health department can track, and if it's their employees, they can track, UMS employees, they can track who are exposed. The general public, we can monitor them.
But I do worry that
I'm sorry.
I do worry that we don't have a system in place yet. If we're going to be doing a large scale screening, so for each one of us, our patients and our employees, we know how to track them. But when we start screening a lot of people, the screens are positive, even if there's no indication for testing. All of those need to be followed up. So we need a common database, but it's not set up yet for. We need to make sure that the operational details are such that none of those screen positive individuals fall through the cracks, right? Anybody
Yes.
that is recommended to be on self-isolation, self-quarantine, will need to make sure that.
We have that database. We've been doing that right from beginning from the Ebola. It's known as RedCap. The database is there. We can give access. So we are asking right now if you can follow up. If it's exposure in the hospital, you all follow up in your own hospitals, like Children's is doing, other places are doing. You follow up your employees. The civilians and citizens who are being exposed, we'll try to follow them up and in the database. So everything will be in the centralized database. You will have access to your employees that you're following. You can monitor, and ADH will also have access. So in that way, there is a database. We have the capacity to do
Right,
it.
so we'll use that then for any centralized
Yes.
screen.
And so do we have full access to the database, or we give you a name and you tell if it's a positive or not?
Down.
No, what I'm talking about, the list of contacts. Say you do, like you have a patient,
Mm-hmm.
your employees,
Mm-hmm.
and we interview the patient too, and you interview also, find out who are your employees are exposed. We interview and find out who are the other non-Baptist or non-children's employees, citizens who are exposed. Have a list of close contacts, put them in our database. So we put the civilians in the database, you put your employees who have been exposed in the database, and then we monitor. And we'll give you access to your part.
So I guess my concern is Jane Doe walks in our ER and says, my brother was tested positive. Because we've already experienced this. A lot of people think that's a pretty good way to get to the front of the line, and it is. We pay a lot of attention to those people. If we could weed out that, the same way that we do with travel, if the patient says, I was on an airplane with someone, I've been told I'm exposed, there's a mechanism for us to find out if they were actually on that airplane. I mean, there's a quarantining system, there's a number you can call. And so I think what would be helpful for us is, I don't want a long list of every positive. I mean, it's a huge privacy concern, but some way that we can validate if this was an actual exposure or someone's just telling us something.
Okay, so what I could do is go back and talk to our folks and legal and figure out if there's any way, they can call our emergency operations center and with some, security things and all, whether we can figure out whether we can provide that information. They have been rightfully exposed. The other problem is many people know who those patients are.
Sure, I can.
So
tell you
that's the other concern. Many people know that I've been exposed to this, but again, that exposure might have been from 200 feet away. So we don't want to test those people. So that is the right reason is that the people who are closest, civilian people who are closest, we will figure out and we'll test them from our database. If they come to the hospital, are admitted and have that exposure, it will hopefully fall onto those individual hospitals to test that. So we are still monitoring, like the cases you had, the civilian part of the thing, we are contacting, getting their names and try to test that. So that's the thing, we have to follow a process or come to an agreement on how to do that.
Can I tell, one of the issues that we've been speaking of here is capacity. And so as your database of people that are under quarantine and you're being followed the database itself has unlimited capacity, but the personnel capacity of the Department of Health to be able to follow these people, what's your saturation rate?
Well, we've pulled, people with some medical expertise from everywhere into this operation. So we're already tracking a few hundred people, the close contacts, that's why we are delegating to the healthcare facility. So again, there are two ways. Most of the time we have, people who are in self-quarantine, especially the travelers and others coming from other, they are self being monitored. If they have any issues, develop symptoms or other things, they'll contact us. And people are falling off the list and people are being added to the list. So again, there will be a point when we'll have to, take help of other sister agencies within the state or, within the cities, to ask them to help us with these efforts.
So from a first responder perspective, I have two concerns. Number one, it's an issue we already have to deal with, is that we're going to encounter 40 or so people every day who present with potential symptoms that will link them to coronavirus. We don't know if they're sick or not, and so we take the appropriate precautions and treat everyone as they may very well be at risk to us. But we don't know if if they've been tested, and we don't know the results of that test unless the hospital takes the initiative, recognizes that EMS, not just MEMS, but any EMS provider, had patient contact with it and makes that notification back to us. So we're kind of
I see.
the relationship we have with the hospitals is fantastic. And they look out for us, but it's not a sure system. And it exposes us to the potential for people who may have met the criteria for being placed in quarantine, for firefighters and police officers who should have been placed in quarantine and never know it. And so I see that as one of the vulnerabilities that we have. And the other question I would raise is that as we start dealing with patients who are being treated at home, is how will we as the EMS emergency response community know that these patients are diagnosed?
So I understand, from where you're coming, and I think we are trying to develop communications now that as soon as we know that a patient is positive, we are trying to let the healthcare provider know immediately, first thing, and then we have coordinated on the situation with Dr. Novak yesterday. So I think that has to be followed. We just let to know whether we talk to the patient and figure out where they have visited, whether they came by ambulance, drove by car, or those kind of things, and then try to hand off to appropriate. So if it is a hospital, so we let the hospital know that they have visited your clinic before coming to, and they are now positive. And EMS is one way we have to figure out whether it goes through the hospital because they dropped off the patient and they would know, because we don't know whether it's MEMS or Saline County or anything who dropped off. So that is one thing that we'll have to come up with a way of notifying. And I understand, you all should know immediately, if a person tests positive.
And it does affect the police and fire community
Yes.
as well, because they may or may not have known to enter with PPE, and now they've had exposure 2 days ago to the patient who proves positive. And if I understand the criteria, they're going to make them eligible for quarantine.
Yeah. I mean, the other thing, I hope you have that in protocol. If anyone is complaining of respiratory issues and other things, if you put on the mask or that, the chances of exposure is very minimal.
Right.
So that's one thing that would help. And again, we'll have to come up with a solution with area hospitals, how to let the EMS, that if EMS is involved, how to let them know, because they will have the information, not the health department.
Then the second question was, as we get to the place where we're treating people in their homes, what notification will there be, besides the patient themselves volunteering this information, that they in fact have been diagnosed, so we know to take particular precautions? Because at MEMS, we're set up to actually go to a higher level of the PPE for known cases.
I think that speaks to the database again, and I think we need some rapid access. And again, I know it can't all be public to us, but there's an HIV database. If everyone that's ever been tested positive in Arkansas is in the database, and we can use that information to take care of those individual patients.
Yeah.
So legally, we need to get that done.
Yeah. So answering your question, you are saying if there is a positive patient, but they are not admitted to a healthcare, they are not sick enough, but they become sick enough. So there are two things, like those are people whom we know are in our database, and usually these people are quarantined, and we provide a letter to them. It states, so and so, you have been either in contact or you're diagnosed, so and so. If you have worsening symptoms or other things, call this number. That notice is there, and again, that can be something that we can say when we have those type of situation. Right now, we are not doing that for patients. We are doing it for close contacts who are developing symptoms. And what we are doing, because the numbers are so low, they are calling us, and if they are falling sick and getting worse, we are coordinating their transfer to the local emergency room. But now here, as the list gets more and more bigger, what we could do is, have a notice or something that's given to the patient or on their house or something like that, that you guys are aware that that's a patient. Or we'll make it, we'll see if we can mandate that the person who is positive lets EMS know that they are diagnosed with that. That's the legal authority.
That's not good enough.
Steve?
MEMS needs access, EMS needs access.
Yep.
We can't put that on the patient.
I'd like to argue for a public resource to help supplement what we're proposing centralized triage center. To answer your question from earlier that nobody answered, I think all of the organizations are willing to help fund and donate in kind, but all of our facilities currently are already pretty stressed.
Right, and that's I agree, and because the message that I think everybody's been saying is stay at home. Candace said that at the press conference. So that's why I was concerned about now trying to develop this centralized place, and y'all are already at capacity.
So
and
I'll just throw it out there, we've talked about asking the governor to activate the National Guard. I mean, there are not any extra healthcare workers laying around, but that's what the National Guard is for public
But
emergencies.
those are the things that I want to talk about today. I mean, if you what y'all have done is great. You call in, what you're talking about is doing is great. For Children's is doing. But there's going to be a group of people that need to have a body look at them. And if they all go to 4 different emergency rooms, all that means that 4 different emergency rooms have to have a special area off the emergency room to be seen, which means that you have to have personnel for them. So, I mean, it's this reduplication of facilities and personnel. So those are the problems we have to figure out pretty quickly. I mean, if you look at what happens with this virus, and y'all know, in just my reading, if there's one today, there's going to be 10, 2 or 3 days from now, and then 4 or 5 days, and there's going to be 100, and then 4 or 5 days later, there's going to be 1,000. And that's just the normal progression of this illness. And unless we go to South Korea, where we run 15,000 tests a day, and we have people spraying the walls and everything, we're going to have a problem more like Italy. So let's just agree that that's a problem and figure out how we're going to do it. And we have to find resources to do it. And that's just a fact of life. And so I think Bruce and I will find a place, but if everybody will go back and say what monetary or physical resources we can do to help do it, and we'll talk to the governor about doing it.
I'll say, and I'm not authorized to say this, but, I mean, Southwest Campus, we have a plan. We have, we have floor plans, we have a plan that I think is almost ready to go, except how on earth could we possibly staff it?
That's my whole point. And then, so if you say, this is a facility we can use, then it's our job to figure out how we staff it. That is, but the people are gonna be here. Now, whether they're out in the hallway, and I mean, one of the things that I was gonna ask everybody is how many respirators do we have in this community to take care of these people? I mean,
Ventilators or N95?
yeah.
Which one?
No, I'm talking about if someone's really, I'm both of them, but the N95 mask I'm less worried about than I am about if you've got, all of a sudden you have this huge spike everybody else has, and we have everybody lined up in every emergency room, and who are you gonna intubate? You gonna intubate Jerry or me? I mean, you know.
You mentioned South Korea, and I do think we ought to take a step back for just a second. I do think, yes, it's not a foregone conclusion that we're gonna see a spike. It's gonna happen, and all these things have to happen. But to what Bruce said a while ago about recommending people staying at home, I do think there are some preventative measures that we may not have recommended to help prevent it from being as bad as it's going to be. So, for example, in South Korea, they went to a public mask policy where the government issued 2 masks a week to every South Korean citizen and asked them to wear that. I mean, we haven't gone that far yet. The question is, should we? And it may not prevent the virus from traveling through the mask. We know that the viral size is pretty small, but we do know that those act as barriers to prevent people from involuntarily touching their nose or face, and some of those can prevent inoculating yourself with the virus. And so I think some of those basic things we haven't gone far enough yet as a community.
Well, that was my last thing about what would you suggest to Frank and Bruce about what we ought to do? We've sent out a thing saying 200 people. But what other things do we need to be saying to the community?
I want to go back to Amanda's point.
Yeah, go ahead.
So we have a public health emergency in Arkansas. We have a national health emergency announced today by Mr. Trump. What else do we need to invoke a public response, a public resource to this? And by that you said, the National Guard, that they have medical capacity, they have personnel. We can still contribute in kind, we should, and there should be a close working relationship with all the healthcare facilities, with whatever resource we set up. But we need that person power to help staff to do the questionnaires, to enter the data in the database. If there's a screen positive, to be trained in using the appropriate personal protective equipment for obtaining samples. We need all that stuff, and it needs to be supplementary to what we have to offer as individual organizations. And I don't know a resource other than the national.
I don't either. It is at that capacity. We are all at capacity all the time. You know, I mean, we just live at capacity. We live on diversion because we don't have any ICU beds. You know, it's just the reality of our system. And so, where do we pull from? And we have talked about you make clinic nurses into floor nurses and floor nurses into ICU nurses, and I mean, there's ways of shoring up what we have, but the reality is, like, we don't have enough. And so how do you pull from completely outside? I don't pull from you, you don't pull from me, we pull from outside the healthcare system, and National Guard's all I got. I mean, if there's any other suggestions, that'd be great too, but.
A mandatory point too is that the staff, as stressed as we are now, as this disease takes hold, our own people are going to be affected.
Right.
And we're going to have fewer of them ourselves.
Yeah.
I may make one other point. I know this is a Little Rock issue.
It's not a
but-
rock issue.
Well, thank you. That's the point I want to make.
You can get over that real quickly.
Exactly, because certainly the men's catchment area is 530,000 people in central Arkansas, but so are the hospitals. And so I think it goes without saying, but I'll say it anyway, that what we decide here has universal application. And so I'm talking across the spectrum.
Are there some simple things we could do just walking out of here to agree on? Because we talked about this initially, just from an adult perspective, agree on some sort of decision support around testing. From a pediatric perspective, agree on some decision support around testing. Have communication coupled with that goes out. Stay calm. You know, here's situations where you might want to seek that out. Here's situations where you don't. Coupled with the precautions that we need to get out there and have people, whatever that is, good hygiene, those sorts of things, stay home. And then work on some of these larger scale pieces where we need to bring other resources in, go back to our organization, figure out what that would look like in a centralized location or decentralized.
And I agree with all that, but the problem is that we don't have time to work on it. So
Right.
let's decide what we're going to do,
Yeah.
and then we'll work on that. Not. So, do y'all think is Southwest Hospital ready to?
It's set up to do a drive-by, and the emergency department, the old emergency department is in good enough shape. The rest of the building, I would not.
Well, again,
Safe as the rest of the building.
can you figure out what it would cost to run it, and let's figure out. Then let's start figuring out how to staff it. And you could do two things there. You can have the overflow from every other hospital. I mean, Amanda's right. And then one of the things we need to talk about is agree on university, not you, not the children's, but the other three hospitals is we're going to have to very quickly start limiting elective procedures. I mean, we're going to have to just go in and say, I'm sorry, I know your hip's been hurting for 6 months and your
The
schedule.
administrators in the room
What?
are about to seize, by the way. But yes, no, I mean, that's a huge decision, but it's part of the algorithm. I think it has to be.
And CDC has already recommended that.
And it's on our list.
Well, but I mean, that is just, and everybody has to do it because you can't say, I'm gonna do my hip at, St. Vincent's, but, Baptist is not gonna do, is gonna, I mean, everybody has to be willing to say, we are out of the elective business for the next month or two if it gets really critical. And that's just a hard fact to watch.
I don't think anyone's going to talk about that on recorded time, but yeah, I think that is a great conversation for us to have offline. I think that's a great idea. As the one telling them that it's coming, it's coming. I think it would be a lot easier for people to swallow if we all jumped in together.
I mean, I think that's the only way of doing it. I mean, we're all in, as far as I'm concerned, we're all in this together, and we're either going to sink or we're gonna all panel together and get that on this deal. So that's just it. But elective cases are one of those things that we're gonna have a hard time, we're gonna have to tell a lot of people who have elective cases set up for 6 months from now, or have had it for 6 months, that we're not gonna do something, and that's a hard problem. John?
We're ready if, to not transport everybody, to, not load them all up on the ERs, but in order to do that, we've got to have that connectivity with whatever healthcare support these patients are gonna get if we leave them in calls.
That's fine. Y'all gonna figure that out. And if we can go to Southwest Hospital and look at that real quickly, that would be an ideal place to have, some place to make sure that they can go and be seen. And then if we have that, when we start having overflow where people can be hospitalized.
Hold on, Southwest Hospital is not ready to be hospitalized, is that what
Right.
you're saying? It is by no means.
That's what I was gonna ask.
Yeah,
What
so
are
let's-
we gonna do
So
at
let's talk
Southwest
about
Hospital?
the drive-through concept and the screening concept, absolutely, ready to go on that.
Then let's get on that one right now.
But the rest of the hospital, there's only certain sections that we're utilizing, the rest, it's an older building.
That's fine.
so-
That, it gives us a start.
Absolutely, I think it's absolutely something that we're gonna be considering as, I just wanna slow us down from fully thinking that's the whole
Right.
I'll
hospital.
take that back from a pediatric perspective too, because we are starting to do that,
Okay.
that drive-through concept, and I can take that back.
When you say drive-through contact, what are you gonna do when you drive through?
So a quick evaluation and a screen and a need for testing or not.
What kind of screening?
Essentially the questions that we're currently asking feeder
Okay.
centers.
So we're not talking about, I don't want them to walk out of here and think that you're gonna drive through and get your mouth swabbed and leave.
That's right.
That is, we're not.
But that may be later.
That
when we
will
develop
be
the
later,
capacity.
and that will be something that we need to do. But we have to understand it's a finite resource right now, screening. And we have to use it wisely. I mean, Jerry
Basically
called me.
screening and triage.
Jerry called me yesterday and said there were 3 people in the emergency room who said, I've had a friend that may have had it, but I'm fine, but I want to screen to make sure I'm okay.
When you're testing.
Yeah.
Not screening, when you're testing.
So,
Mr. Swanson, I had a question. So you are saying that your folks are going to evaluate the patients there, and if they don't need to be transported to hospital, if they're stable enough, you want someone to follow up on them from the health department?
he wants a way to tell you on that group of people that they call and say, are you doing okay? Is everything going okay? And one of the questions I'll ask y'all is, if you say to someone, we're not testing them, are we gonna tell them they've gotta stay quarantined for 2 weeks if they have the flu? I mean, it's a real economic issue. If you say to someone, you've got fever and chills, but you don't need to be in the hospital, they can have the flu. Do we say to them, they have to be quarantined for 2 weeks? I mean, I don't know the answer to that.
So I think part of our plan is testing for those things that are easy to test for. And so, I mean, to me, there's no well, I say that. Eventually that might be scarce too. I mean, a lot of people, we're doing a lot of flu tests for the end of flu season. But for now, we have the capacity to test for flu and RSV, and next week we'll have the whole biofire. Well, we can test for a lot of things besides COVID-19. And I think offering that to people,
I think that's great, but what do we tell these people that we've now gone out to meals? You're not sick enough to come in. We're gonna watch you. Do they tell their employer that we've now told them to stay home for 2 weeks? I mean, there's a real economic problem that we're creating in what we're doing. And
The we has to be sanctioned by the health department, and then that means, yes, you're staying home for 2 weeks. That's what it means when you're,
Which could
have a public
decrease
health
the
emergency.
ultimate economic risk of that person affecting more and more. You know, the 10,
Yeah.
100, the 1,000.
So
So-
I want to get all these things out. These are all the questions that people ask me, but these are real issues. I mean, if we say to someone, you drive by, you've had these symptoms, go home and self-quarantine, are we telling everybody that has that problem they're going to have to be home for 2 weeks?
Well, it's, so again, to Amanda's point, you need to make a diagnosis, right? So, to me, each one of those patients needs follow-up, either with their established healthcare provider or a new place, right?
We already are, stretched to a limit, and we are handling the closest contacts and following them. To have that perspective, to follow them up, again, most people I'm hoping have some sort of primary care provider or something that they could lean back on. So that is where I think, they have to fall back on. I mean, for the health department to do all that, it would be near impossible. I mean, I don't know how many people you call upon. It was another 100 people per day that you are going to call upon, and for us to that additional 100 besides that, it is not. And again, these people right now, we don't have rampant community spread like it happened in the New York area or in the Seattle area, that everyone has to be screened or tested. And again, not to work is another issue. Like, every hospital has different issue. For flu, they are out for 3 days or 5 days, 7 days, depending on the hospital policy. If they are diagnosed, that's a different. And again, if you see what was done in the certain counties in California and Seattle, many of the healthcare workers, because they were burnt out, have been asked to come back to work in 7 days or 5 days. It all depends on how the situation evolves. What we decide today may not hold true on Monday. So,
But here's the problem. If they're a Baptist or Children's and they have an illness, it's real easy to say, you're my employee, this is what happened, this is what you do. Or UAMS or St. Vincent's. But if you're John Q. Person that worked for the city of Little Rock, and you come in and we say, you've been sick, you've been exposed, we want you to self-quarantine for 2 weeks. What are they going to tell Bruce when they call in here and say, do I stay home for 2 weeks? I mean, it's a real economic issue.
that is where the questionnaire that everyone agreed, your risk of getting the disease, your risk of being tested will come into play. If they are lowering the risk, even for exposed people, right now CDC has a guideline of high exposure, medium exposure, low exposure. Many healthcare settings are asking people with medium and low exposure to come back to work. And some hospital people, even with high risk setting, they have been asked to come back and work with, because they might be the only person there in certain hospitals. So have been asked to come. So we'll have to, maybe come to an agreement, or, see if, CDC has some guidance, or the health department can work on some.
I would like to make a plug for just the whole idea of flattening the curve, and by having non-healthcare workers go ahead and distance, have social distancing, I think closing the schools, church services, AA groups meeting by phone conference or whatever that is, then you have fewer people out there spreading it. And therefore you have fewer healthcare workers that have to be quarantined for 14 days. I mean, it really is, like, we definitely have to figure out what we're going to do with our exposed healthcare workers, but that whole idea of getting everyone in the community involved in slowing the spread of this with social distancing, I mean, that's how we keep our nurses healthy.
Well, then now that Frank's here, and that's the same question I asked before. What were you going to tell Frank and Bruce on how we can flatten that curve? Because I think that is the key thing that I want. That as I went to them and said, this is a really big deal. What do? We've said 200 people. We've strongly suggested you don't do it. What else do we say to the community today?
May I ask a question here?
Well, hold on 1 second. Before you say we just left and came back from Governor Hutchinson's, he is now adhering to what we've already been strongly urging, and he's now moving that to a 4-county radius. So the Jefferson, Grant, Pulaski, Saline, that's what he recently announced, that he's going to be having that same urging as well. So that's something good.
Okay, so schools, communities of faith, and we're talking about church services here?
Urge.
Okay, right.
directed.
I mean, I think
Yes.
that that's.
We've urged anybody of 200 people or more to not do it.
Okay.
But I've had 2 calls today, and I'm not sure why they're calling me, but who have church services of 50 people, and they said, should we meet? I'm in the handbill problem. I said, don't, wait till Easter. It's the 16th. Maybe we'll, we all be resurrected by then. But, I think anybody that has anything. Cappy Peck just went on and said, here's what I'm going to do to stay open, but these are the things I'm doing. You just do things that make sense. I mean, but I'm telling anybody, I have an event that I do with the city that we've already canceled. We had 3 or 4 events that we've all canceled. But it's just, we need to be saying to everybody, if you have an event, don't do it. If you have people coming to town, don't do it. If you have people that come in for a big conference, don't do it. It's just, it's crazy. I mean, that is the biggest, if we have that spike that you read about everywhere else, we're in real trouble.
So moving from there, we got that strong urge. I'm assuming, because I know Chairman Capiris was talking about mobile testing sites. Did we come to a finalization there?
We're going to look at Southwest.
Dean and I are ready to go.
Yeah.
So since you guys are ready to go, let's just try, if at all possible, make a decision on that by the end of tomorrow.
We're going
Or
to
sooner.
we're going to look tonight at the hospital and do it. Let's just start.
Workforce is the big.
Yeah, that's
Yeah,
what I'm saying. That's the
yeah,
issue.
yeah.
I mean, we got to know what we're gonna have out there. I mean, that's the biggest
Yeah.
issue for me. I mean,
And that's, so let me sum up, because everybody's looking at their phones like they're getting called. So I'm sorry. We're going to look at Southwest, and you're going to see what we can do there with testing and limited examinations.
No,
The-
not testing, right?
Not
Screening.
Screening,
So-
screening.
Assessing,
We will-
assessing, we need to use the
Assessing.
right language.
And we will do the same in children.
Okay. We're going to look at, in my understanding that everybody's got some different facility in each hospital. If you come in and say, you know, if you're sick, you've got some other place to go other than the general emergency room.
And I'd just say too, Dean, pharmacies can help with the screening process. So, it's another location that is really plentiful in all the areas of the town without having to make folks drive.
So Scott, if you could get us a list of pharmacies who would be willing to participate in screening.
Absolutely. We just.
Assessing.
Yeah, that's what I mean. Obviously, not
Yeah.
testing. Although we do flu testing in many locations, if that is needed. But absolutely, we can get a list of all the Pulaski County, Little Rock area pharmacies. I think that'd be very helpful.
The problem with food testing is if you do a swab and it's wrong diagnosis, you just expose the person taking the swab. Right, so given where we are right now,
But they are doing it,
That's anybody that does the flu testing though, so, as long as we're wearing the right PPE, it's.
So we're going to start on that. Bruce and I'll see if there's any other location. We'll talk to everybody individually about staffing. We're going to get, Stephanie is already on top of getting your numbers out, and we'll start the PSAs. The paper's going to put things in it. We'll start that immediately on what to do there. And then next week, when we'd all like to get back together. I know that no one wants to do that, but
There's one thing to add, we are closing the schools and other things, for a couple of weeks, but, we need to be aware, 2 weeks is too short of a
I'm going
period.
to tell you, they're not going to be, well,
We need to make sure that the expectation should not be high.
It's 2 weeks is a
Too short.
nanosecond in
Yes.
this thing.
So that being said, can everybody be here Monday or Tuesday at 1 o'clock?
let's go for Monday. Do we?
Yeah, Monday.
Monday at 1 o'clock. 1:30. Let's say Monday at
I'll tell you
1:30.
about 2 o'clock, because I've got to see a few things. 2 o'clock.
May I ask a quick question? Are you all using the word screening or assessing, or what is the exact word we're using?
Assessing.
Assessing.
Was it assessing and something though, or just?
No,
assessing?
we're not treating, we're assessing.
We got one last question from Mr. Snell, and then we'll conclude after Mr. Snell.
Yeah, thank you, Mayor. As the Executive Director of the Housing Authority, I have a couple of clusters of very vulnerable individuals. So I would like some suggestions or some thoughts with respect to how we should address this, because these are individuals that are in high rises, they are, have pre-existing health conditions. The social distancing is not something we can apply in these situations. And, we are getting information to them, but they're high-risk individuals because of a multitude of things. And I just want to bring that, to the discussion, because I think as we look at where we're going to be putting testing centers and where we're going to be doing things, I think for my demographics, we know where some of these individuals are.
It may be easier to come assess them there, have someone there.
Yeah.
Yes, sir.
Again, the public message, service message should go is that, people should wash their hands every time they eat, and anytime they eat anything, wash your hands with soap and water. Try to avoid touching your facial parts, and if possible, not to meet. This cannot be overemphasized. There's only two ways you can, and again, if people are sick, do not go outside, do not be with other, if you have one apartment next door, no, try not to go. There's only two ways you can spread it. If some sick individual is coughing and sneezing on you and you're about 3 feet away. The second is, if you have an infected person who's coughed and sneezed and you touch that area and then touch your face. It's very simple. So people practice hand hygiene. It's not just COVID-19. All viruses, including the flu, can be prevented if they practice these types. That messaging has to be reiterated.
And that will be Stephanie will give you the first thing on her public service thing. So let me just tell you, you're going to look at legal, what Amanda was saying legally about how we tell John's group what's going on. Bruce and I will work on a site, and then I'll call each one of you individually about staffing, about what we're going to do. We'll get the children's number out and UAMS's number out, what we're going to do. Y'all are going to look at Southwest Hospital about assessment. See, I got it right this time. Assessment, and then the message will be that we're going to send out. If you think you've got the flu, stay home. If you've got the flu and you're short of breath, call and come in. Hand washing, and then we're going to have to, everybody needs to go back to their institution and say, how are we going to take care of this elective surgery? Because if we don't do that, as soon as it happens, we're going to do it, and then Frank and Bruce and I'll talk about flattening the curve.
And I just think that Monday at 2 is when all of the hospitals need to be able to come back and tell us what capacity they're going to be able to help. Mayor, one of the things that Amanda mentioned was maybe asking the governor to activate the National Guard to help facilitate this facility. And I think Dean, right now we ought to focus on Southwest Hospital. I mean, all of our facilities aren't going to have the capacity or even the equipment. So let's see if that's viable, and then who all can participate.
Who's y'all's lawyer? Who's that? We need, whoever y'all's lawyer is, we need them here.
We'll get one of them, one of our legal
because
counsels.
we need to be able to push this to the limit to make sure that we don't, because I mean, literally, if we get hospital personnel sick, MEM sick, policemen and fire department sick, then we're in real trouble. And the other issue is, legally, if you tell someone to stay home, and if they don't stay home for 14 days, what happens, or can we say that?
We have powers for quarantine, if they're really this thing and they're moving out. We've had law enforcement involved in that also.
Okay.
And I had a request for Mayor Scott. Around the table, mostly are medical personnel. One of our important partners is business owners. In fact, the business owners and factories and other people. If we could have few people, because the message they send out to their employees also is very important. Citizens.
Yeah, we're in constant contact with the business community.
Yeah,
That won't be an issue.
But we just, and thank y'all for coming, and I'm sorry that I'm so abrupt and push things so hard. So I apologize to everybody right now, but, you replace me and I'll be someone nicer and easier to deal with. That's okay.
Thank you, guys.
Thank you.
Thanks.
See you Monday at 2.